Hey, BC here for BC Nephro. Today's topic, the use of immunosuppressants in kidney disease. When I first was preparing this topic, I felt this need to be comprehensive to include every immunosuppressive that can be used for any kidney disease. But then I remembered the 80-20 rule. What is the 80-20 rule? Also known as the Pareto principle. It says that you get 80% of results from 20% of causes. So in that vein, I'm going to tell you about 5 different immunosuppressive agents. And if you know these, you'll know the vast majority of treatments for any glomerulonephritis nephritic syndrome or nephrotic syndrome glomerulopathy. So let's get into it. First, steroids, glucocorticoids. These can either be given as IV pulses or oral. The oral can be given high dose as primary therapy or low dose in combination therapy. I don't need to go into the whole list of side effects and complications, but some things to be mindful of are this. Prophylaxis against pneumocystis if you're using more than 20 milligrams a day for any prolonged period of time. Reactivation of hepatitis B or latent TB. Screen for these things. Peptic ulcer disease and bone disease. Give prophylaxis. What are they used for? So pulse steroids 3 days in a row are used for any rapidly progressive glomerulonephritis. They also can be used for a lupus nephritis flare or as part of a treatment for membranous nephropathy. Oral can be used as primary therapy for some glomerulopathies. Minimal change focal submental glomerulosclerosis can be used for IgA nephropathy. And low dose can be used in combination for many of the nephrotic syndrome glomerulopathies. My take, the pulse steroids are frequently needed in these severe cases and it's useful to give. I would only give the high dose steroids for a short period of time, no longer than 2 months. If you're using it for longer than 2 months, the patients are going to get cushingoid and have a very high chance of having complications. Either a rapid taper after an RPGN pulse treatment or in a condition where you expect a very quick remission, like minimal change disease. I frequently will go straight to the low dose in combination for many of my nephrotic syndrome treatments. Next, cyclophosphamide. So cyclophosphamide can either be given as IV cycles every 2 to 4 weeks or as oral at a dose of 1.5 to 2.5 milligrams per kilogram. There are a lot of potential side effects here, so you need to be mindful of an infection risk. An effect on fertility in women can affect the ovaries, as well as prolonged use can lead to bladder cancer or a myelodysplastic syndrome. The uses. The IV regimens are useful, in my opinion, for lupus nephritis. I prefer to go to the oral regimens in treatment of RPGNs like ANCA disease or in membranous nephropathy. My take is that it is often a very useful treatment. When it's used, it's more likely to cause a durable remission. It might be the most likely to cause a durable remission, but certainly more likely than the calcineurin inhibitors. Many nephrologists shy away from these because of the concerns about the complications. The concerns about the complications are real, so I certainly would avoid it in elderly or frail people, but in other cases it can be very useful and may be underused. If you're going to use it, check a CBC with DIF twice a month to screen for leukopenia, and don't use it for more than 6 months, as the risk for myelodysplastic syndrome and bladder cancer have to do with cumulative doses. They say a cumulative dose of 36 grams increases the risk. If you're using it for only 6 months, the oral regimen, you're going to be using only 9 to 12 grams, so you'll be well beneath that risk. Third class of drugs, calcineurin inhibitors. These are given orally, either cyclosporin or tacrolimus twice a day. They are used for primary therapy along with low-dose steroids for many of the nephrotic syndrome glomerulopathies, and also as a part of a multi-targeted regimen in lupus nephritis. The concerns would be they can cause nephrotoxicity, so if there's already a decreased GFR, there's a concern there. But if you target lower doses, lower trough levels, you should be able to get by with this. My take is that these are very likely to have relapses, so you have to use a prolonged course for 1 or 2 years with a very slow taper. After that, you need to make sure you follow the trough levels. There are many P450 drug interactions that you need to be aware of. Fourth class of drug is Rituximab. Now, Rituximab is given IV. It's typically given in 2 1-gram doses separated by 2 weeks, and then a maintenance dose every 6 months for a period of time. Now, this drug is often considered a safer alternative to cyclophosphamide, but it certainly is by no means safe. There can be anaphylactic infusion reactions, there can be leukopenia and prolonged hypogammaglobulinemia, and an increased risk of infection. It's a treatment for ANCA, GN, and it is also a treatment for membranous nephropathy as an alternative to cyclophosphamide. My take, it is useful when the patient may be at increased risk of adverse effects from cyclophosphamide, such as an older or frail patient. When used in membranous nephropathy, there will likely be a delayed onset until you see the decrease in proteinuria, so you have to deal with that. The fifth one we're going to talk about is Mycophenolate Mofetil. Cellcept is given orally. The side effects here are diarrhea and leukopenia. It also is teratogenic, cannot be used in pregnancy. And for most of these drugs, you should also avoid giving live vaccines because of the immunosuppressed state. It is used in lupus nephritis as an induction and maintenance agent as an alternative to cyclophosphamide. On my take, this makes a lot of sense since a lot of people with lupus nephritis are young women, and you have the concern about fertility, the effect on the ovaries, and so mycophenolate is an effective and good alternative in these cases. So there it is, 5 drugs. It may be more than 20%. I didn't do the math, but you certainly, I think this, if you know these 5 drugs, you will know more than 80% of the treatment for both glomerulonephritis, nephritic syndrome, and glomerulopathies, nephrotic syndrome. So if you made it to the end of the video, thanks for watching. Hit the like, subscribe, let your friends know who may benefit from learning about this, and until next time.